For joining. My name is Jennifer Cartland, and I'm the Vice President for Data Analytics and Reporting at Lurie Children's Hospital in Chicago. Very excited to be here today and share some great work with our colleagues across the country. We have three presenters. Our focus today is on the role of analytics in hospitals dealing with social determinants of health and trying to meet their goals there. This is it's an old saw for people in public health, and I think all three of our presenters have a background in public health, but for many health services researchers and indeed for hospitals, it's a new area to explore. So many of our analysts across the country are being asked to think about problems in a new way as hospitals are thinking about problems in a new way. So we have three terrific presentations to share with you today. And I'm pleased to introduce our first presenter, Carrie Carstairs. She's an MD from, I apologize, I had this all set up. She's an MD from Rady Children's in San Diego. She formerly was in the ED, but is now their Chief Population Health Officer. So I think she can talk with a lot of clarity, or at least immediacy, about the issues around social determinants of health for our analysts who are on the phone here. Her research interests have been in healthcare systems and outcomes research, and she's focused currently on improving services for children making sure our hospital does a great job at addressing social determinants of health. So with that, I'm going to welcome Carrie and let her start her presentation. I do want to note to all of our listeners that we will be looking at comments for questions, and we'll be holding questions until all three presenters have done their presentation. And so thank you, Carrie. We look forward to hearing what you have to say.
All right, thank you for the introduction, and I will bridge that a little bit with, I think as an emergency physician, there's a lot of surprise when someone moves into a career around population health, but I think with respect to population health and bad outcomes of bad population health management, we see that in the ED with respect to overutilization and bad disease management, which is what drove my passion in the next phase of my career in population health, which I actually just started in the last month. So very excited to be here, very excited to take on this role, as I've spent many years scratching my head over what we could do better with the children in our community and beyond. So this is an initiative that we started actually because we knew that asthma was very prevalent in our community. And a lot of people say, well, Southern California is beautiful. You don't have the same climate change like they have in the South or the North. But as it turns out, when we looked at our RCHN, or our clinically integrated network prevalence, we actually do have a very high prevalence of almost 9% in children under 18 years of age. This is a population of about 300,000 children that are capitated within our CIN. So we know we have a problem. We're about 50-50 Medicaid in our CIN. So it's not just children with Medicaid or commercial insurance. We actually know that we have a prevalence that matches that both nationally and is actually a little bit higher than the prevalence in our state. The CDPH report is old, it's from 2014, but I don't think it's changed that much. And so you can see when you look, we have a prevalence of 8.6, and in the state of California, 8.1. The last CDC report was 8.3. So we knew we had a problem. Asthma obviously is a continuum of care. And so we know that here in our organization, as in many other organizations, this is that continuum we see. The most important one being at home, right? And then that partnership with primary care. Oftentimes they come into the ED, worst case scenario, inpatient admissions, and even worse, PICU. And then many of our children in our organization, when they get to that point, end up being managed in our severe asthma clinic. Most of our asthmatics, however, are managed by the primary care physicians. Our specialists run a severe asthma clinic for children with very severe refractory asthma. So we knew that a partnership to get patients back to primary care with the families was going to be key to success in improving our asthma outcomes. So this is obviously the ideal asthma management goal. For me in the ED, the panacea of asthma is they never come in, right? They're managed well, they're on controller medications to keep their disease at bay, see their PCP to manage that piece of their asthma, understand their asthma action plan, and they're able to thrive at home, especially children. So we know that this is the perfect story. We don't ever get there anywhere, but we want to set this really high bar to keep kids out of the ED, out of the hospital, and at home being managed by their primary care physician. So this is a little bit of background on the team that worked on this together. We have a team here that others would probably refer to in their organizations possibly as their population health team. We call it Care Redesign, and it's a partnership between primary care, frontline hospital teams, which are comprised of our specialists, our inpatient physicians and nurses, our respiratory therapists, and many of the administrative support teams in the background. We had a CMS grant called the TCPI grant, Transforming Clinical Practice Initiative, that focused specifically on bridging gaps between primary care and hospital-based practices with respect to asthma and many other conditions, with asthma being the most important. And then, of course, there's the IT piece. We couldn't do anything that we have done without our IT, both analysts and builders and reporting. It's just been key to moving things forward, and I'll show you some of those examples in just a moment. So this is the team that really worked closely on this initiative together. So we launched this pilot in 2018 with some initial goals to reduce utilization and monitor return rates to the ED and really improve overall outcomes. We look at things like the asthma medication ratio to make sure that they're on a controller more than a rescue inhaler, to get kids back to their medical home, and really to provide a lot of education reinforcement. And we couldn't have done any of this without paying very close attention to our patient and family engagement. We have a family advisory council that gives us input on any educational materials we roll out, and then also empower families and children as well around self-management at home. So our process that we developed included developing a script, having a staged rollout, where we initially just called patients in the ED. We then rolled it out to an inpatient pilot where we included any patient admitted. We knew there were going to be some seasonal challenges, so we made sure that we rolled it out prior to the winter season, which was why we picked November 2018. And the script was developed really around having a patient care coordinator initially call the family, and then if needed, escalate it to a respiratory therapist, just so that we were using the right people in the right space, and also being cognizant of the cost. RT is an expensive resource, it's a very necessary one, but for a quick phone call to make sure they filled their prescription and are seeing their primary care physician wasn't necessarily in the scope of an RT. We then developed a dashboard to identify and track the patients so that when they logged on every morning, they knew which patients needed to be called from the previous day or perhaps hadn't been contacted from the previous attempts. So here's a dashboard development snapshot of what we developed. So I'll walk you through this a little bit. What would happen is a child would come into the ED, and we built in the background with our IT team a trigger that would look for any patient that came in with the diagnosis of asthma, history of asthma, wheezing or cough, because we wanted to make sure that in case it didn't come through as a diagnosis of wheezing, cough, shortness of breath, and a history of asthma, that we didn't miss those kids. All of those children would then be put into this dashboard so that the PCCs and the RTs would constantly be able to go in and see who's been called, who needs another call, and who to continue to call. For example, not everybody always is going to answer. These were 8 to 5 pilots, Monday through Friday. Often people are at work. And so we would make 3 attempts, and this was their list that they would work from every day, and they would all share that. So we didn't always have the same person working every day, but this was a way for them to communicate consistently. So I'm going to jump right into results. So what was really fascinating with us is you can see here that we contacted about 30%, 20 to 30% of the patients that were actually seeing the ED, which is not a bad contact rate. It sounds low, but as it turns out after ED visits, that's about consistent. We divided it into 2 patient populations to analyze. We looked at our Medicaid populations and our commercial populations. And this was all comers, actually. This wasn't just in our CIN. We actually pulled all patients, about 40% of which are in our CIN, but we wanted to look at this impact on the entire community. And what we found with the patients that did answer the phone call and received the education, that with respect to a 7-day return rate, we dropped that percent to 2.87 as compared to the other population of 7.92. And with a 30% return rate, similar results. So you can see 7.9 compared to 13.6. So we were really proud of this. Previous to this, when we looked at return rates, we were looking around that same number, 7 or 8%. And so with just a simple phone call, and I'll have another slide in a moment, you can see what an impact of calling in, because many of you have been into an ED, it's chaotic, it's often late at night, there's noise everywhere, you get this piece of paper when you go home. It's really hard to know what you were supposed to do and what you heard, because a parent brings a child into the ED for an asthma exacerbation. It's scary because their child couldn't breathe, which is why they came in. So now they've had 24 hours to sort of digest it, and much of the information is lost and forgotten because they're tired and it happened in an unscheduled visit. Commercial rates were even more impressive. So our 7-day return for those that received a phone call was less than 1% at 0.4%, compared to over 6% for those that didn't answer the phone call. And then you can see 30%, nearly a third reduction to the cohort compared to those that did not receive a call. So we thought these were really important rates that we wanted to share with you. So in addition, we had 910 patients that were successfully contacted over the course of that 12 months. As I said, about a 30% contact rate. And these were just some other data that I wanted to share with you, just so that, if anybody wants to implement something, how you can sort of plan. So initially a PCC would call. About 20% of those needed RT education. And these were families that just didn't understand how to use an inhaler. And we actually would do a telemedicine visit with them, or didn't really understand their asthma action plan. And we just felt that it was better for them to hear that from an expert. About 48% of them actually didn't know how to connect or hadn't connected to a PCP visit for follow-up. That was eye-opening to us. We all know that sometimes that happens, but that medical home connection will be critical for them to continue to manage their child's asthma moving forward. 80% of them actually did pick up their prescription. Now, the prescriptions are few and far between for asthmatics, as most of them are maybe getting a course of oral corticosteroids. But 84% of them actually felt better prepared by just a simple phone call. And so, this isn't, we didn't do a statistical significance analysis on this. This was just some questions that our team gathered as we were moving forward. So we have a lot of other things going on, as I'm sure many organizations do. Asthma is one of those that it takes everyone on board, the family, the primary care team, the hospital-based team, the specialists. So we have actually built on some of this work and continue to build on it with our monthly reporting, with our CAM, where we look at PMPM rates with respect to ED utilization, PCP visits. We follow the HEDIS measure of the asthma medication ratio. We give individual practice reports. So in our CIN, they will know which practice and which individuals within that practice have asthmatics that are more fragile than others, so they can plan for interventions. We're constantly modifying our guideline with up-to-date management recommendations, and sometimes there's things that aren't available when inhaler shortages occur. We use our Family Advisory Council very frequently on input on what helps with education. We have a really nice order set and pathway that we've developed around the continuum, where if you're seen in the ED in a primary care space within our network, inpatient, or even worse, PICU, everything is aligned so they get the same treatment and same evaluation and asthma scoring as they would in any other area. We have a Candle Collaborative, as many other organizations do, where our nurses are helping to work on transitions. We've developed a severe asthma dashboard and referral triggers. So if a child is admitted for the first time to the PICU, that patient automatically gets a referral before physicians. We recently received a grant to do home visits, which we have actually been able to move forward during COVID using telemedicine, which has been eye-opening, but not surprisingly so, around some of the environments that children with asthma live in. But it's allowed us to really see, for example, we saw a child whose bed is under a window that's often open because the family can't afford air conditioning, and there's a flowering tree outside of that window. So obviously a trigger for this child, and the parents just didn't think about it, and it was as simple as putting her bed actually in a different bedroom. And so those kind of things have been really fascinating to go into the home via telemedicine with them carrying around their camera and showing us. We also have some QI projects going on in the ED that I've listed here, where we are now continuing to, starting and continuing to distribute over the last year inhaled corticosteroids, and I think other organizations are doing the same. So I wanted to thank our entire care redesign team, which you see on this list. It's obviously not just me. Charlie Davis is our Senior Vice President over care redesign here at Rady Children's, and I report to him in my role. Dominique Hensler is our Senior Director. Rhonda and Donna are our Nursing Directors. Miriam is our IT Analyst. Danny is my right hand QIA MPH, who's smarter than everyone else on this team, and Jacob Parker, who some of you on the phone may or may not have worked with in the previous. He is one of our population health analysts and helped us develop a lot of those dashboards that I just showed with you. So I will stop there and entertain any questions, or we can hold them till the end.
Thank you, Carrie. Right, everybody write down your questions. We are going to hold them to the end just to make sure we have good time for everybody. Thank you, Carrie. That was a great presentation. Really appreciate it. Really appreciate what you guys have learned and that you're sharing it with us. I'm going to turn next to Sean Soyson. Sean is a statistical analyst at Primary Children's in Salt Lake City. He's got his master's in anthro and PhD in public health. I always like pulling out the anthropologists. It's just a great set of skills for the kind of work we do. But he's going to talk about lead poisoning, what they've learned in terms of lead poisoning in their population, and how it does or doesn't underlie some of the other social determinants of health and health status indicators. So Sean, take it away.
Okay, so I'm going to share my screen here, and then I will get started. All right, let's see here. Okay, so today I'm going to be talking about how we used our lead testing data to understand the current state of lead testing in our patient population, how we adopted a consistent testing standard that we're now using across 37 clinics that see about 80,000 kids annually, and how we have used that data to dramatically improve our HEDIS lead screening in children metrics, as well as the proportion of our Medicaid population that's been screened. Just as a background, individuals with high blood lead levels often don't show any acute symptoms. So the effect of lead poisoning can really go unrecognized for years and years, and only manifest at times when it's too late to intervene. So even short-term exposure early in life can lead to irreversible effects on a child's physical and mental health, and that includes impaired memory, executive function, behavioral and learning problems that can last throughout the course of an individual's life, lower IQ, hearing problems, impaired growth. And there is some evidence that about 20% of all ADHD cases may be attributed to lead exposure. And so many of these effects are often observed in individuals with only 2 deciliters, 2 micrograms per deciliter over the detectable level. So low-level exposure can lead to very serious long-term outcomes. And so this is just, I think, a nice illustration that shows sort of as exposure increases, all of the potential, or at least a sample of the potential adverse long-term outcomes. And, you know, lead is a neurotoxin in children, but you can see that these are not just neurological symptoms. These span from metabolic, gastrointestinal, endocrine, and renal effects as well. And this is just a chart of sort of at the various levels of exposure that there are decreased test scores and all kinds of educational achievement outcomes that can dramatically affect the course of someone's life, someone's earning potential, someone's career opportunities. All of these things are highly detrimental to kids that are exposed to lead. There are multiple ways that kids can be exposed to lead. So there's dust and soil in and around the home, and these can be historical exposures, even going back to the time before all of the lead abatement projects and initiatives began, where we are still seeing lead, because it has a very long half-life, existing in soil from leaded gasoline from 40 years ago. Which is of course a very serious problem in areas, especially low-income areas, where improper soil remediation hasn't taken place. And of course, there's the very common problem of kids being exposed to paint, peeling paint, kids eating paint chips, or dust from from inside the home environment that they would get exposed to. And then there's also take-home exposures, where we have individuals that are employed in industries like construction, demolition, recycling, manufacturing, and agriculture that are bringing those, bringing lead attached to clothing into the house and then exposing children via that pathway. And one of the things that we have observed kind of across the board is that communities of color and low-income areas are disproportionately affected by these types of exposures, both because of housing conditions, but also because the individuals in these communities are more likely to be employed in those industries that were mentioned before. They're more likely to bring in to have those take-home exposures. And so in addition to that, communities of color are often just excluded from policymaking decisions. So they're subjects to policies that are inconsistently applied across communities as a result from being excluded from those decisions. And there, of course, is a really steep cost to remediation efforts, both on the individual level and the community level. In communities where the effects of wealth inequality are felt very severely, this can be a significant barrier to remediation efforts, which are often just not done or are incompletely done, which can put people at an even higher risk than if remediation efforts were never started in the first place. And then there's also just the pervasive issue based on generations of structural discrimination and racism. The communities that are at high risk of exposure are often stigmatized for the impression or the perception that they're not keeping their kids safe from lead due to individual housing choices, the housekeeping or parental decisions. And so, we have this situation sort of because of this moralist tradition that we have in this country of blaming populations for being in the situations that they're in, especially when it comes to health disparities, which of course are things that are beyond their control. So, we've observed that Black communities are often at higher risk of exposure, even compared with white communities with comparable family incomes. And even, I think this was mostly observed in cities like Chicago and Boston, but these effects are real. And so I think, I think it really underscores the sort of the health inequity component of lead exposure. Comes from a study from the Health Impact Project, which looked at whole blood lead level results from 2011 to 2014 that found that the proportion of detectable levels was twice as high in Black children compared to white children. This is a very large study. There's a population of 10 million white children and almost 3 million Black children. So in Utah, the Utah Department of Health estimated in 2015 that only 3% of the population of children between 1 and 6 had been tested for lead even a single time. Testing is mandated by CMS for kids on Medicaid, but statewide we were only testing historically about 20% of the Medicaid population. And so with those things in mind, our HEDIS lead screening in children measure really hadn't improved in years. And so probably one of the biggest barriers that's confronting widespread lead testing standardization efforts is that there's this perception that lead poisoning is a part of the past. And I think to a certain extent we can kind of be forgiven for that because we did have all the lead abatement efforts that started in the late 70s. They were incredibly successful in bringing down the average lead level across children over the following decades, about 90%. But we've reached a point where that reduction has truly plateaued. And so, we were seeing the same effects in marginalized populations, largely due to the factors that I outlined in the previous slide. And that trend of steadily downward, but the slope of that line over time in marginalized populations was definitely not as steep as in white populations. So, what we needed was a reporting system, a comprehensive reporting system to understand the lead testing situation in our population. Because prior to 2019, we really didn't have an understanding of the proportion of our patient population that had been tested at all, at what age we were typically testing, whether our clinics and providers were adhering to testing guidelines, et cetera. So it was decided that we needed a comprehensive system to understand these testing patterns and something that might help us determine whether we have a problem with lead in Utah, whether there are certain areas that are disproportionately affected, as has been observed in many other communities throughout the nation. Can we prevent long-term health-related outcomes in children? And can we change our culture of lead testing by increasing provider accountability, enforcing compliance with national testing standards, and then making those standards uniform across all of our clinics that provide care to children? So the solution was to build a lead testing dashboard, and this is just an overview of all of the tabs that are currently being used. And so this brings in, it combines data from multiple data sources. So we have our clinical data repository. We have EMR data that spans 2 medical systems we have results going back to 1999 and then with the addition of raw result values from internal and external sources that come through our general lab schema in our EDW. So we started with 18 pediatric clinics in January 2019 that all agreed collectively that they were going to adhere to the CMS mandate for the Medicaid population, but then also expand that to also be adherent to the HEDIS measure of testing kids before the age of 2. So our dashboard allows providers to build cohorts and create custom views, set alerts, monitor the proportion of their own panel their patient panel that has been tested. And we have geocoded addresses that can be plotted along with the lead test results to map down to very precise localities so that we can try to identify potential lead hotspots. And one of the biggest things that helped with adoption across all of these clinics is that we've tied this to physician compensation. So there is sort of like there's a penalization aspect to providers not meeting their lead testing targets. And so this is the distribution of our participating testing sites across the state. Again, went from 18 just pediatric clinics, but now has included family medicine clinics as well. And this is an example of sort of the heat map that we've been using. So we've not done much actual spatial analysis to try to determine whether or not we can identify statistically significant clusters of lead exposure. But we do have a way of seeing where kids are testing positive. So we can zoom in on those areas and identify areas that we might target more robust abatement efforts. And so this is just showing the data that's been flowing into the system. Loaded all of this historical data, but then as we the yellow is when about the time that we started implementing our current system, our Cerner product, iCentra. And then this in 2019, this is when we started this effort in our outpatient clinic. So you can see the raw number of tests coming into our system just exploded. So about a month into us going live with this tracking system, there was a winter storm that caused a power outage that led to an overfeed of fluoride into the water, which corroded the pipes in the water in Sandy, Utah, which released a massive amount of lead into the water supply. And so at the time, the highest observed water level was 394 milligrams per deciliter, which is about 26 times higher than the action level. So about 2,000 households were affected, potentially 8,000 individuals. So there was a little bit of a lag from them discovering that there was a problem to when they released that information to the public. So that was about midweek, February 15th. So by the time, Intermountain Healthcare organized a massive testing effort that began on Saturday, February 23rd. We tested about, I think, 1,000 people just in that area over the following 2 weeks. And so during those testing efforts, we found that there were 29 children under the age of 10 that had tested positive for a detectable level using the point of care, so that finger stick capillary test. But only 7 were confirmed positive by venous testing. So we were lucky that this did not become the issue that it could have with such high lead levels in the water and such a serious potential exposure. You can see that on the 23rd, that was the day that we were setting up testing stations at all of the local clinics, in parking lots, and any place where we could do it. We mobilized all of our available lead analyzers and the people that were trained to use them, and we sent them out, and people could just show up and get tested. So this is down here a distribution of the results by age of the people tested. So luckily, we truly did not have the problem that we expected, again, with such a massive amount of lead being released into the water. But I think that this really underscored the need for a system like this, because we were ready with the reporting infrastructure to be able to look at this and pretty immediately examine the severity of it. But of course, it's the real value of this is not in these, sub-catastrophic events, but in the ongoing monitoring of our population to see how we're doing, and to identify kids for early intervention, to hook them up with the Department of Housing, to start remediation efforts in the home, and things like that. So these are our participating clinics, and just you can see that when we started this, the year before, hardly any tests being done. But then once we initiated these testing protocols, they increased rapidly, as did the number of tests, the detectable levels. And the detectable level was reduced. I can't remember exactly when, but it used to be 5 micrograms per deciliter, but now it's 3.3. The tests have gotten much more sensitive. And in 2012, the CDC took the official position that there's no safe level. So we're saying that any detectable level is actionable. And I think that this is probably the visualization that I think that really shows just how successful that we've been in increasing our HEDIS lead testing in children metric, where we started with only about 13% of our population between the ages of 1 and 2 being tested, and then over time that getting all the way up to 77%. And you see the uptake in in some clinics has been a little bit better than others, but overall, our clinics and our individual providers have done an amazing job in increasing the proportion of their population that's been tested. So just to conclude, understanding our population has really allowed us to set provider level targets and really improve our overall lead testing compliance in both our pediatric and our family medicine clinic, and hopefully expanding into other areas where care is provided for pediatric patients. And you can see just that those proportions just changing over time. And one of the big lessons was that really providing individual clinics and providers with access to their metrics really allows for more accurate measurement and for goal setting. And it's really taught us that, despite the perception that, that lead testing for kids really isn't necessary anymore, that, we have observed many detectable tests that, confer a high risk for very serious long-term outcomes in children. So it is still absolutely necessary to continue in these efforts. And so now that we have a much larger data set, we can start looking into whether or not the same issues with inequity in lead testing and lead exposure that has been observed across the country exist in our own population. And so these are just preliminary results, not quite ready to publish these yet, but we have definitely observed an increase in the odds of having a detectable lead level in Medicaid insured kids compared to commercially insured, non-white compared to white individuals, and a further stratification of that subpopulation. There's a very large increase in odds in Black compared to white individuals.
Great. Well, thank you, Sean. What a great presentation. Oh, I apologize.
That's okay.
We do need to wrap it up, though, because we need time for questions at the end.
Absolutely. And I just wanted to say one more thing here. So we did, earlier this year, there was a joint resolution that was aimed at comprehensively testing and really trying to avoid the long-term effects. So this was sponsored at the state level by Jenny Omoto, and data that was used from our system, especially the mapping, was really able to sway them to support and ultimately pass this resolution. Okay, and that's what I have. My special thanks of people at the Department of Health, our leadership at Primary Children's and Medical Group. This has truly been a collaborative effort with a lot of physician and analytics champions stepping in to really push this along and make this as successful as it has been.
Great. Thank you so much, Sean. What a great project.
Sure.
Really, really interesting. Lots to learn there. Now I'm going to turn it over to Tracy Smith, who is the Director of Population Health and Research Analytics at Lurie Children's. Tracy has a master's in public health, in maternal child health and epidemiology, and is going to talk today about the hospital's efforts to make sure our actual tracking of race and ethnicity is accurate so that we can actually get down to understanding social determinants of health in a deeper way. Take it away, Tracy.
Sorry, I just realized that I had muted myself and I didn't know how to unmute in this screen sharing environment. So thanks, Jennifer. As Jennifer mentioned, I'm going to talk today about our sort of efforts to evaluate health equity. We'll talk about the health equity, what we do at the hospital in general, and then we'll get into the specific project that we're working on. And so just a couple fast facts about Lurie Children's. I learned this at Epic. Epic always does this to people who present at Epic, so I stole it. But anyway, as many of you know, we are a freestanding children's hospital located in Streeterville, neighborhood of Chicago, so just north of downtown, kind of in the Magnificent Mile. We have 364 beds, 17 outpatient centers and partner hospitals. In 2019, we had over 11,000 inpatient admissions, which translates to about 92,000 patient days, over 55,000 emergency department visits, and enterprise-wide, we saw about 220,000 unique patients. So I'm sure many of you have seen some sort of graphic like this before, this one, I like this one. Aaron Paquette, who's my who co-chairs a committee with me and who is the co-author on this presentation, brought this to my attention not too long ago. You know, a lot of these we see it's equality and equity, right? Equality is giving everyone the same thing. Equity is giving everyone what they need, but this takes it a step further and moves to justice, where the actual cause of the inequity is removed. So in this case, the fence becomes chain linked instead of wood, and so everyone can see through it automatically without any need for anything else. So I thought that was pretty great. So our health equity at our institution, you know, there have been many efforts, research, otherwise, for years and years, but sort of institutionally, I feel like it seems like things really got started in 2016 when we were working on our community health needs assessment. The Chicago Department of Public Health has always been a great partner, and they came to us and they had just finished their needs assessment and said, hey, you know, we really tried to take a health equity lens, looking at all our metrics. And, you know, for the pediatrics, we use this Child Opportunity Index, which some of you might be familiar with it. It was developed at the collaboration between the Kirwan Institute at The Ohio State, as well as Data Diversity Kids. And the idea is it takes a bunch of different factors, social, economic, health factors, and creates an index that has 5 different levels, from very low to very high opportunity. And so we said, yeah, that sounds great. So we actually did all of our priority health measures. We looked at by not only Child Opportunity Index, but race, ethnicity as well. And full disclosure, this is actually from our current CHNA, but the colors were nicer on this one, so so anyway, these graphs are ED and hospitalization rates for asthma. So on the left, you'll see the by Child Opportunity Index, the blue being very high, the red being very low. So as you can see, as opportunity sort of decreases, the rate of ED visits and hospitalizations increases. And then you can see the distribution for the race ethnicity on the right. And we found this to be the same distribution basically for all our priority health conditions. So really kind of the next step institutionally was the creation of what we call healthy communities. And the idea behind healthy communities really was to serve as a hub between our clinical efforts and our community health efforts and our research efforts. So I'm not going to go through this, but I just wanted to pop it up just to show you sort of the depth and breadth of what really healthy communities really covers. And this really gave, you know, some of the things that we talked about in our implementation plan some teeth. So something, an organization that was in charge of sort of making those things happen. And then about a couple of years ago, we formed this health equity task force. And it was sort of the same idea as healthy communities. Like, we know all this stuff is happening in the hospital, but no one really has their arms around it. So let's figure out what's happening. And then, are there gaps? Like, are there places where we, as a task force, can get some momentum behind things? And we sort of organize things into these domains: performance outcomes and barriers, workforce equity. So there's a lot of movement around getting community members employed at Lurie Children's, implementation and education. So we've done some health equity grand rounds. There's implicit bias training being planned, things like that. And then collaboration, like we just helped work on an institutional statement on racism. So there's a lot of different pieces to that. Sort of during that same time frame, we were recruiting and since onboarded a vice president and chief of diversity and inclusion. And so she has this, you know, whole vision and a strategic plan she's working on. And then once it came time for 2019 community health needs assessment, really all the equity, health equity stuff was already brewing. So it was much more focused this time around on health equity. And then in FY21, we are planning on implementing a social determinants of health screen. And so that is in the works now. And really during this whole time, we continued to use the Child Opportunity Index. Really, Healthy Communities uses a lot to help with prioritization. And then we also use it for, say, emerging health topics, like for example, COVID. And so we, once all the, news had started to come out that, African Americans and Hispanics were disproportionately affected by COVID, we decided to look at the data by Child Opportunity Index, because that's something we had available. We didn't have necessarily the, the counts of African Americans in a certain zip code, but we had Child Opportunity Index. So on the left, you'll see it's a map, and the color of the circles is the Child Opportunity Index level. So the darker is the lower, the very low, and then the lighter is the very high. Then the size of the dot or bubble is the rate. So you can see that the darker dots have the higher rate. So that was pretty interesting to watch. And then we sort of moved on after sort of the initial peak had sort of ended in Illinois, and I started creating these small little charts that are the 7-day rolling average. And just so you can see sort of the differences in the COVID experience among those. And those aren't rates, those are just counts. So, but still, you can still see that the areas of very low or disproportionately affected. So as far as health equity data Illyria goes, like the Child Opportunity Index is great, but it's a community level factor. It's not a patient level factor. And so the Health Equity Task Force really, pretty much as soon as we convened, everyone was really hungry to look at patient outcomes and quality metrics by race and ethnicity and primary language. But there was sort of a general sense of sort of distrust of the data that's recorded in our medical record. And so we did a little research and, found that there were, people have done studies on this, and there really is variable concordance. And, there are studies that 80% concordance up to 95. So it really ranged. And so we decided to design a quality improvement study to address this data accuracy issue and to see how our data are. And so the project, what we did was we identified 8 clinical areas that had high volumes and diverse patients so that we could get, get enough diversity to make this worthwhile and statistically strong. So we decided to do it in 2 prongs. One, we would survey 2,000 patients, and our pre-COVID plan was to have the survey completed in Qualtrics, which, if some of you don't know, is a HIPAA-compliant online survey platform, and we use it for a lot, and it's pretty versatile. And our survey items would include sort of our standard demographics, and then also we figured while we're asking questions, we should go ahead and ask phone number, email address, and mailing address to see how accurate those are. The preferred language we actually spent a lot of time thinking about, and I think might yield the most interesting results. Because I don't know how your EHRs work, but in our EHR it just says preferred language. And so we don't know, is that the patient or the caregiver, and is it written or spoken? So in our survey, we actually ask 4 distinct questions. What is the written, what is the preferred written language of the patient, if they can write? What's preferred spoken language, etc. So we're really excited to get a look at that. And so this, and we did translate the survey into Spanish as well. And the idea would be that in the research assistants would go to a clinic with an iPad and approach the patients and ask them if they'd like to complete the survey. And then we had this flyer, and there's a QR code at the bottom. So the patient can either take the QR code, do it on their own personal device, or the research assistant had an iPad and they could, scan it for them and help them do it. So that was kind of the plan. We were supposed to start on April 1st, which obviously didn't happen. So our COVID workaround plan then became 2-pronged. So we, in early May, had launched a survey to patients about their experiences using healthcare during our stay-at-home order. And so we decided to add race, ethnicity, and just 1 preferred language question to that. Race is always an issue, just to really give us a jump start, and so that we could do something. And then our phase 2 plan is more like our original pre-COVID plan, which was we did basically get a report of all the patients seen in those 8 clinical areas in the previous week. We text them on Monday, we send a reminder text on Wednesday, and then the following Monday, whoever didn't get complete their survey gets put into a queue to be called. And we have a coordinator and 2 interns that are going to be making calls. So that's the plan. And then the other prong is to talk to the clinical leads and other staff in these 8 clinical areas to really understand how these data are collected. If they get a new patient, what happens? Do they update it and things like that? And then the idea is we'll look at concordance in each of these areas and really hope to identify some areas that do really well and can basically create some best practice from that. So our analysis plan, honestly, it's pretty simple. We take the self-reported data from the survey, we looked at what it says in our EHR, and we see if they're the same. We do, and this is another thing we've done institutionally recently, is made essentially the declaration of when we report race ethnicity, we do so as one combined variable. And so we take Hispanic and then the other races are non-Hispanic. And then, as I mentioned earlier, we'll look at the rates of concordance in each of those clinical areas. And so the results from our COVID survey, we had what we felt was a really good, swift response. We got about 4,200 respondents who answered these questions, and that was about a 15% response rate. We had reasonable diversity in responses. We did do some weighting in our actual survey, but honestly, it was pretty minimal. So we were pretty happy with the response. So these are the results. And so what we have here is basically if the respondents self-reported these races, and then the percents represent basically how often we got it right in our EHR. So you'll see that, the top 3, it's not terrible, but then it starts to drop off a little bit. And we really feel like the drastic room for improvement is around those patients who identified as 2 or more races. So basically, if on the survey, the respondent said the patient was 2 or more races, only 29% of the time did it say that in evidence. And so I think that, if we were just using this as our whole thing, I would say that is definitely the place we need to focus. I've heard, I've not confirmed, that Epic used to only allow you to select 1 race. And so some of this just might be legacy. And so, we'll definitely see if the same patterns emerge with our next 2,000 patients, and then come up with some ideas for that. And then we looked at the preferred language. So basically, if the preferred language on the survey was Spanish, 20% of the time in the EHR, the preferred language was English. And so once again, we kind of expected this to be an issue, just because in the EHR, it's not very precise. We don't know if it's the same person even answering the question. And so that is what we found out there. And so really our next step is to start the texting and follow-ups. It's very imminent. It's going to happen very, very soon. We actually did start piloting some of the calls, and then to do those key informant interviews and start to strategize about ways to accuracy. I want to acknowledge all the great help, our Qualtrics queen, which is Emily, and then Anne and Mia, who are on my team and who put this data together, and then our research coordinator. Okay, was that fast enough?
Thank you, Tracy.
Sure.
And Carrie and Sean again. It was a great series of presentations. I think all of our participants, all of our registrants have a lot to think about. I'll give you all a chance, if you have questions, if you haven't done so already, putting a note in under comments. We'll communicate that to Amanda and Ashley. So Amanda, Ashley, have we received any questions?
Yeah, we do have a question. First question is for Carrie. What platform was used to store and capture the data after using Epic to generate the list?
Epic. We just kept it all in Epic. Specifically, what are you asking? How did we analyze the data? Everything was contained completely within Epic.
Okay. Thank you, Carrie. thank you. Any other questions, Amanda?
Yes, another question for Carrie. For the care redesign, have you applied to populations besides asthma?
We haven't yet. We just finished this pilot at the end of 2019, and we're starting to look at potentially rolling it out for others, and then COVID, like everyone else, derailed a lot of our planned efforts. But we've sort of come into our new steady state with COVID, so we're definitely looking at this fiscal year of rolling out new projects.
Exciting.
I have a question for Sean. Was there effort or thought to include prenatal patients in the lead testing?
That's a very good question. So that is not a thing that we have talked about, but I think that is definitely something that would be worth exploring. So, you know, typically, like the American Academy of Pediatrics and CMS, and you know, a lot of the associations that make lead testing policy recommendations typically start lead testing at 12 months. But I definitely think that it would be very interesting to see what in utero testing, what the patterns would be for in utero testing. So that's a great question, and that is definitely something that I will bring up to our leadership.
Thank you, Sean. So interesting.
I have a question for Tracy. What is the process at Lori for collecting race, language, etc., data from patients and families?
Well, that's what we want to learn. I mean, I think that we have a general idea, but I think the reality is that there's variation across different clinical areas, or if it's ambulatory versus the ED versus inpatient. And so I think that's part of what we're trying to learn. And so that we can, you know, if we do feel like there's an improvement project needed, that we can tailor it appropriately for all areas. So yeah, that's part of what we're trying to do.
I remember a study years ago in which they were just trying to figure out how ED folks, this is years ago, how they identified ethnicity, and they did it by name. Yeah, and it was totally inaccurate. But that was like in the 90s. So it's just interesting how these things evolve. So any other questions?
Nothing so far. That's it so far.
Great, thank you. Well, I'm going to close it down because we're at time. Really, just a great set of presentations. I want to just thank Carrie and Sean and Tracy for sharing their work with us. I know that they'll be willing to answer any questions. If anybody has any additional questions, feel free to let us know, and we will make sure that we connect them with you. Thank you all very much. We have another panel next week on the 7th. We're trying to do these every other week, but it just worked out to do next week, which is on enabling self-service, a culture of self-service in your organization. So I hope you can join us for that. Thank you again. Have a wonderful weekend, everybody. And the weather's great here in Chicago, so I hope it is where you are too. Take care.
Bye, everybody.
Bye-bye.